Hello, and welcome to Psych Incubator, a product of Strategic Psychotherapeutics. We are very pleased to feature as our eminent psychotherapist this month, Dr. Jeff Harris. Jeff is a director of counseling at the Aggie Health Wellness Center at New Mexico State University. His PhD is in counseling psychology from Ohio State University. He's board certified as a specialist in counseling psychology by the American Board of Professional Psychology. Jeff is an amazing teacher, and I say that because I've had the privilege of sitting in his lectures and seminars. Jeff has a way of reducing very complex material to understandable bits, which I think is such a delight, because so many of us get so esoteric that I think we lose the people teaching. So Jeff, you will not find Jeff, maybe you will a little bit, but you won't find him to be this up in the sky person. He's written a few books. His integrated multi-theoretical psychotherapy book, I think, is an excellent read for anybody who's interested in learning about unified psychotherapeutics. So without further ado, I am going to start our discussion.
Well, I'll introduce myself, and Michael, maybe you could introduce yourself.
Sure.
I'm Barbara Ingram, and I was a professor of psychology in a graduate program at Pepperdine University for 44 years. And I'm celebrating the third month of my retirement. But I've been very involved with the unification movement, and I'm happy to be here today.
I'm Michael Albert. I'm a psychiatrist. I've been working on the development of brief models of psychotherapy for the past 50 years. Fell on my face a number of times, but I'm really pleased by all the advances that we've made recently, and find that doing this work and playing with these ideas to be just something that you can't buy. It's just a wonderful gift.
Okay, I'll plunge in with my first question for Jeff, and it's sort of a historical question. Jeff, when did you first find yourself attracted to an integrative approach?
Okay, thanks, Barbara. So I got my PhD in counseling psychology at Ohio State University in 1990. And we, unlike many programs, we were not encouraged to choose a specific orientation. So we had exposure to different theories, but there wasn't pressure to choose one orientation. But on the other hand, there were no methods for intentional integration. So I think that I came out of grad school with an approach that was based on common factors, but was somewhat eclectic. In 1995, I attended the Evolution of Psychotherapy conference. And for those of you who aren't familiar with that, it's one that they do every 4 or 5 years and have big name figures from many different approaches. And that was the first time I said, maybe I want to learn a little bit about psychotherapy from these different approaches, although I wasn't using the word integration yet. In 1996, I went to a presentation by some colleagues at a conference that introduced the idea of integrative psychotherapy. I bought a copy of the 1992 first edition of Norcross and Goldfried's Handbook of Psychotherapy Integration, and then I taught a class to some of the grad students at the university I was working. And one of the things I realized was that how I integrated psychotherapy was different than most of the approaches. And a lot of the approaches that were published in the first handbook were talking about how to choose between when to be cognitive or when to be experiential, when to be psychodynamic or when to be systemic. And I realized that in my own work, I was usually combining those in a single session, and that I was looking at the interaction between these emotions were learned in this family system, or these behaviors are part of this cultural context. And so I started trying to describe what I was doing and how that might be different than other approaches. In 2001, I presented for the first time, and I had a 75-page Kinko book with a little plastic binding with almost no references. It took me 7 years to make that into a real book. The book that Jeffrey mentioned is, oh, see, I got my camera blurred, so I can't.
Hold it still, just hold it still for a minute. Hold it still.
Okay.
No, it doesn't work. Oh, there you go.
There it is. There it is.
There it is.
There you go. So I published this book in 2008. It's out of print, but because it's out of print, I can give you free copies if you want any copies of the chapters. And then I started attending CEPI at that time, and eventually I met colleagues like Jeffrey and Barbara who were doing similar work, trying to fit most of the approaches to psychotherapy together, and we gathered around the topic of unified psychotherapy, and that's been really enriching work. And what I've been doing the last couple of years is designing a training program called Training in Unified Psychotherapy that I'm pilot testing this summer, and will be offering through the StratPsych platform in the future. So that's a long answer, but 1995 is the short answer.
It was a very great answer. Thank you.
Yeah, it was a seems like a spoken from the heart experience, and that you kind of found your way. So after looking at integrating these things and believing in the importance of that, can you kind of give an example of how you use this approach with, let's just say, a person who comes in to the door who's an obsessive and over obsessing and worrying and obsessing and worrying. So how do you approach someone like this? How do you kind of combine all the different factors that you look at so that they can move along quickly?
Okay, sure. Thanks, Michael. So in trying to describe a big picture unified model of psychotherapy, you have to decide how many pieces you're going to cut the pie in. And the way I cut up the pie is similar to the way Jeffrey and Jack in their book have, or Barbara did in her book. When I wrote the book 15 years ago, I had 7 dimensions. Now there's 9. 9 is a lot to take a hold of, and so I've divided into 3 levels. And so the first level, which I call immediate psychological experience, is the interaction between cognition, emotion, and behavior. So the idea here, this central triangle is that people are always thinking, feeling, and acting. So that's where I start. And then I look at external influences and then internal influences. So in the unified model that I teach, there are 4 external influences, which is development across life experiences, interpersonal patterns, social systems, and then cultural contexts. And then the two internal influences are unconscious processes and defenses and biological health. So I always start with thoughts, actions, and feelings, and look at that interaction between cognition, emotion, and behavior. And then I look at external influences and then internal influences. So Michael, you said someone who was obsessive. So I would look at, any problem is an interaction between of thoughts, actions, and feelings. And so someone who has obsessive compulsive disorder is going to have obsessive thoughts. And so it's important to look at those thoughts and, the obsessive thoughts, maybe if I stop trying, I will fail, and so that's driving this kind of obsessive pattern. There may be compulsive actions, like always working and never taking a break. And then there's going to be emotions, and it's important to figure out what the emotions are. And so with someone like who's obsessed with success and is compulsively overworking, the emotion may be a fear of failure, or something like that. So I always start with that interaction between thoughts, actions, and feelings, and then try and figure out where we might want to change that for, and I want that choice to be up to the client. So instead of saying, I'm a cognitive psychotherapist, we're going to start with changing your thoughts. In the same, I want to leave that up to the client and ask them where they want to start in terms of thoughts, actions, and feelings. Then we're going to look at external influences. So that may be, you know, the family. My role in the family was to be the hero and to succeed and make the family proud, or be a good example for my siblings. And for each client, the where those external influences came in may be different. And then we're going to look at, over time, look at internal influences, both biological and the unconscious. So that's my general approach: is thoughts, actions, and feelings, external influences, internal influences.
This makes a lot of sense. Yeah, there. If you want, this is, you know, I can, maybe it'll, I don't know if this is a good time to do this, but to have you demonstrate it, I could be an obsessive patient,
Okay.
and then you would demonstrate how you use this, and I would respond. But
Okay.
you may not want to go down that
No, let's do
rabbit
it.
hole.
Let's do it.
Okay. Okay. So
I'm gonna take notes. So Michael,
So-
when you notice that you're acting in this obsessive way, let's describe your thoughts, your feelings, and your actions, and we can describe them in any order. You want to tell me about your feelings first, your thoughts first, or your actions?
Oh, I can't stop thinking about how I'm gonna solve. I don't know how to solve this problem. I mean, my life is falling apart. I used to depend on my wife, but I think I'm driving her crazy now because I'm just worried all the time. I'm worried that.
So one of your thoughts that I wrote down is, my life is falling apart. And then you said something else that I didn't quite get. I don't know how to solve this problem.
Right.
And what's the problem you don't? So when you think, I don't know how to solve this problem, do you apply that to everything, or is there just one problem you don't know how to solve?
Oh, it's a lot of problems. It's a
Okay.
lot of problems.
So
You know, it's,
you may have a different problem on different days or different weeks.
yeah.
Okay. So, and
And-
then the third thought that I heard you say that I haven't written down yet is, I'm driving my wife nuts. Is that what you said?
Right.
So some of the thoughts that are associated with your feeling obsessive is, I don't know how to solve this problem. My life is falling apart and I'm driving my wife nuts. Is that a good
Mhm.
sample of the thoughts?
Yes.
Okay, let's talk about, do you want to talk about feelings next or actions?
I guess actions. I need to solve this. If I don't solve this, I don't know what's going to happen.
So when you think these thoughts like, I don't know how to solve this problem, my life is falling apart and I'm driving my wife nuts, how does that impact your behavior?
Impact what?
Your behavior, your actions. How do you act?
I just keep making mistakes. I say the wrong things. I want to help, and I seem to get in the way. I irritate my kids. I just.
So
You know.
what are the particular actions that you do that are, it sounds like they are attempts at solutions, but they don't end up being helpful. So what's an example of an action that you take?
Oh, if my kids are fighting, I try to solve the problem, try to help them get along and treat each other better, and to treat, one's a boy and one's a girl, and they've usually got a boyfriend or a girlfriend around, and I try to smooth things over, but they usually find that I'm, you know, it seems like it gets better for a short time and then it's worse.
Okay.
Instead of
So,
things getting better.
But from your perspective, what the actions that you're taking are you're trying to solve problems and you're trying to smooth things over.
Right.
So at least from your perspective, solving problems and smoothing things over, those are things that you're trying to do to help solve problems. So that idea of solving problems and being helpful to the people around you sounds really important.
Yes, yes.
But it sounds like the problem is that it doesn't have the impact that you want.
No.
Okay.
We get rid of that.
So I'm curious, Michael, when you try to solve problems and smooth things over and it doesn't work out, then what do you do when you get some pushback from your family?
Oh, I just, I worry. I start, I've been taking some medicine, trying to calm myself down. The medicine just
So you
makes
end
me
up feeling
anxious and depressed,
anxious and depressed.
and depressed.
So let's move on to feelings. So when you feel anxious, is that feel like a type of fear, or does it feel like a different type of emotion?
It's fear.
Okay.
I'm terrified.
And what do you know when you feel terrified? What do you feel afraid of? What is the fear about?
Let me just get rid of this.
Yeah.
So we're not a bit. Okay, good.
So what are you afraid of when you feel terrified, Michael?
I'm afraid that my family's going to fall apart, that my kids aren't going to get along, that my wife's going to leave me, and that I'm just going to just have nothing.
Okay, so I heard two different fears there. One is kind of a fear of failure, that you won't be able to help your family, and that your family will fall apart and you'll be alone.
Pardon me. Yeah. Yeah. Let me give you a different number. 973-903-1323. Just call that number. Where are you located?
Okay, Michael,
Okay, great. Go ahead. Okay.
So I heard two different fears there, Michael. One was kind of a fear of failure, that you would fail to help your family, and then as a result of that, you might be alone.
Yes.
Okay, so there's a fear of failure and a fear of feeling alone, being alone. So with the feeling of depression, does the depression feel like sadness or disappointment, or does it feel like a different emotion?
I don't know. I just feel I've got no energy. I can't do anything. I just I cry.
So Michael, when you cry, are you aware of feeling sad or feeling disappointed, or is it still the same feeling of?
I'm sad. I'm sad.
Yeah. And
very agitated, very shaky.
When you feel sad, what do you feel sad about?
I just ruined everything. I just ruined everything.
So let me tell you what I've gotten in terms of your thoughts. You said that I don't know how to solve this problem. My life is falling apart. I'm driving my wife nuts. Some of the actions are trying to solve problems and smooth things over and worrying. In terms of feelings, there's a feeling of anxiety, which seems to be related to a fear of failure and a fear of being alone. And then there's some sadness, which seems to be, a feeling of regret that you may have ruined everything. When you think about these thoughts, feelings, and actions, what I would like you to do between now and the next time we meet is to each day when you're feeling depressed or anxious, I want you to jot down some of what the thought is, what the feeling is, and what is the action. So some days you may be feeling more fear, some days you may be feeling more sadness, and I think it's important to look at these.
So let me write this down because I'm not going to remember it. So I should.
Each day, when you're feeling either anxious, depressed, I want you to write down something that you're thinking, something that you're feeling, and one of the actions. And then when we meet next, we're going to look at those patterns and see the patterns of the thoughts, feelings, and actions, and then we're going to look at that and see how we might want to change that pattern. Whether we want to start by trying to explore and change some of the feelings, explore and change some of the actions, or explore and change some of the thoughts. And
Okay, when can I see you?
we can meet again next week. Does this time work for you?
That would be one. I might need to talk to you before then because I don't know if I can wait that long.
Okay. So yeah, so I think that's still some of that fear is coming out for you, that fear of failure, fear of being alone.
You're right. That's what that is. Okay.
Yeah. So let's meet at the same time next week and we'll look at the data that you've collected about your thoughts and feelings and actions, and then we'll look at the patterns and then figure out where to intervene.
Thank you very much, Doctor. Thank you.
Okay.
Thanks.
Wow. So
that's something I do. That's something I do, with most clients is I look at the interaction between thoughts, feelings, actions, and then ask them to collect some data in order to look at patterns. So that's one way to start an integrative approach.
Yeah. And you're very,
systematic.
It decreased some of the anxiety,
But
Well,
I
the name
thought
what it was.
I felt like you were, you were trying very hard to kind of give me something to hold on to.
so. As I was watching it, I thought, Michael, you played out, you acted out a perfect passive aggressive personality. You answered the phone during the interview, and I was wondering, like, how would you characterize, like, if that was a patient that was doing what he was doing, answering his phone and playing, how would you address that stuff in the session?
Well, for me, we just talked about I have to solve the problems. So the person on the phone, had a problem that Michael needed to solve. So I think it was a great demonstration of that.
Right. Michael, you fell like into the role completely. I was like getting irritated, like, oh my God, this is so passive aggressive. He's talking on the phone while he's in an interview.
Well, it's it may be passive aggressive to the psychotherapist, but he needed to feel connected to the person on that phone.
Right, but didn't he say?
It was three different things all related to the same thing.
Yeah, but wasn't it related to what he said, how he pisses people off? He tries to help, but he winds up irritating people, right?
There's no question there was an unintended consequence, which is one of the necessary precursors before you die.
So what was the experience like for you, Michael?
It was of answering the phone, or
No, the whole thing.
The phone made me truly anxious.
Yeah.
I couldn't play the role because I had to answer this.
Well, you were playing
phone.
the role, actually. You that was part of. I mean, that fell into the role of.
Well, it didn't feel part of the role to me because I don't think that this person would have answered the phone.
No, he would just let it ring and ring and ring.
I don't know what he would have done, but I think
This is an issue I have with a lot of patients who their phones ring and they sometimes answer their phone during the session.
mhm,
How do you?
you know, if it takes a second, it takes a second.
Sometimes people actually, I think, do it so I can hear the conversation. They want me to witness how they're and this does not happen infrequently. It's like, okay, so they get a phone call and they go like this and they have a talk with the person and they're wanting me to bear witness to it or something. I don't know. There's so many different
It's a
dynamics.
sample of behavior. It's a sample of behavior in the same way, when you're doing couples counseling, when they start to have a fight, let's collect some data.
Right. So everything's a sample of behavior, right? Everything.
Yes. Yeah.
So
Yeah.
what?
So if I had more time with Michael, I might have said, did you feel like you needed to solve their problem?
That's exactly what was going on there. I had to solve this problem, so I get rid of this damn phone call and get back to the.
I just want to comment. I'd like to comment, Jeff. First of all, I just appreciated you jumping in and doing that.
Yeah.
We did not rehearse this, so that was great. And I really like how you did two things. Like you stated exactly the same level of abstraction as the client, but then you got a little more abstract. So like you were saying something like a fear of failure, or so I thought that was a good intervention, or just, showing flexibility. But then I had a question. When you were asking for behavior, he never really gave a behavior. Like what he did is he gave an intention. Like, I want to smooth things over and this and that. So would you have let that go? Or would you have wanted him to, the client to get more specific? Like,
Well, it's always
what
funny
does
doing
that-
a demonstration because
Yes,
I'm
of
trying to do
course.
something in 10 minutes that I usually
Yeah.
do in 45. So I was curious about that in terms of what does this problem solving behavior look like? What is the smoothing things over? Because of course, part of the problem was he's trying to solve problems and he's not, yeah. So one of the things in terms of collecting data for the next week, I thought about asking him to identify how he's trying to solve problems, and one of the common communication errors that people make is that they give advice rather than support, things like that. So I'm curious. Yeah, I'm definitely curious about his attempts to solve problems that is pushing people away, and
Thank you.
and some hypotheses like, I wonder if he's giving advice rather than support. I wonder if he's, yeah. So that certainly I want more depth there, about more specifics about the behavior that he feels is supportive, being a supportive father or partner that is having the impact of driving people nuts.
Thank you.
So at a go ahead.
No, I mean, this is, it's interesting because, you know how I was kind of clinging at the end there, and I was going to, what if I have to, I was portraying someone who actually would want to talk to me every half hour if possible.
Yeah.
Very,
And which I think is that fear of being alone. Yeah, so I think that by answering the phone, you demonstrated some of the actions about wanting to solve problems. And can we meet before next week? Was that fear of being alone?
Mhm.
So on another level, I thought your skills were very, very precise, and I really like the way you work. And what I was thinking, I'm agreeing with what Barb said in terms of at the level she was talking about the intervention. But I thought that in a way, Jeff, what I could say you were masterfully doing is differentiation, and that sounds like such a obvious thing for a therapist to do. But with a patient like Michael was portraying, the therapeutic process, I think, requires so much differentiation because people often do not know the difference between thoughts, feelings, and behavior, or let alone different emotional, like what is that sadness, like, is that sadness about something, or is it a state? So I thought that was very systematic and well done in terms of helping Michael to begin to begin to start some mentalization, to begin to be able to, okay, so when I try to help people, there are all these components to it. I find myself irritating people, and that's not what I want to do, but I find myself irritating people. But when you can see why, with the clinginess and the projection, and it's his anxiety that he can't manage, right? So he's looking to help other people because that's a way that
I'm going to give you a field day because I have to go into the door now.
all right. So I thought that was very systematic and well done in terms of.
But I want to point out that, and one of the things when I teach is that we have a tendency to emphasize what we want to emphasize. So I think Barbara's point that I went in more depth with emotions than the actions is true, because I prefer to work with emotions than actions. So I think I'm doing what I encourage people not to do, that I left it at, I try to solve problems and I smooth things over, but I did go into more distinction, more differentiation with the emotions. So,
But you're saying that you kind of, that's a bias, but I think that any clinical decision point is trying to access the affective zone, so people can get more in touch with it and process it, because the thoughts and the beliefs are intertwined with the affective experience. So
absolutely.
So we really put you on the spot there.
Can I kind of, that was a great example. That was kind of dealing with how you function as a clinician. I'd like to just open a topic of you as an educator and trainer of therapists. And, I think it's great when you describe your TUP program, that you're piloting it. I've seen bits of it. It's like extremely well organized. But I'd like to know some of your thoughts about the types of students that you think are most likely to become good therapists, or, when you first meet, let's say, a candidate who wants an internship at a counseling center, do you have a sense? Well, I've stopped talking and let you answer.
Let me say a couple things about training. I think that one of the things that Jeffrey and Barbara and I were talking about just before the webinar started was this idea of being an integrative psychotherapist or unified psychotherapist is an ambitious learning project. And so I think that I'm attracted to teaching people who are always open to learning, and I think that learning new things and fitting more pieces together. So we all know people who say, I learned this theory, I'm going to do this method, I'll just keep doing that in the same way forever. And I think that that's attractive to one, learning style. But I enjoy working with the people that are always trying to learn more and fit more of the pieces together. So that curiosity and that commitment to lifelong learning are two things that I think is attractive.
I call that, everybody, if you have a hammer, everything's a nail.
Yes, absolutely.
Approach, right? If all you
got my hammer, so look at all these nails.
And I did that for years in different approaches, especially when I was in training in intensive short-term dynamic therapy. Like, this was my approach, and by God, even if it wasn't, I wasn't really thinking about treatment selection, differential therapeutics. I was thinking about, this is the approach and this is what you need. And then you get iatrogenic disturbances, because obviously if the approach does not match in terms of the values and the beliefs of the person we're working with. The best approach, like one of my supervisors used to say, the operation was a success, but the patient died. You used your approach well, but patient didn't come back or got worse. So do you think patients do get worse in psychotherapy sometimes?
I mean, I think they drop out. So it's, the people that, I think there's obviously people who aren't ready to change or who need something different than what we're offering them. So I think that people drop out and don't get better. I think that in terms of the getting worse, there's some, I'm sorting through the pain, this is, and many of us use the medical illusion that we're going to be picking shrapnel out of this wound and it's going to hurt, but we're doing this so that we can clean this wound and you can heal. So I don't know if people get worse, but people have pain before they get better, and then other people aren't benefiting from what we're offering them for one reason or another.
Okay. When you were talking about thoughts, feelings, and actions, and the assignment was to each time to write them down. What was it and which one of these categories? So you were attempting to get me to begin to separate things out and look at them instead of just being this frenetic flurry of anxiety. Now there's each of these areas is very important for many reasons. So one of the areas, let's say, for instance, the feeling area. People have, if you ask people about a feeling, you get well, I feel worried, or I feel angry, or I feel upset, or I feel this, and then have they told you anything? How do you take it beyond that to the next level? Because obviously each of these things could mean something different to somebody else. So you have to get clarity on what they're really talking about. So how do you go about straightening it out so you can see what each of these things is?
So yeah. So if Michael, if you were my client and you came back the next session and you had some data, and we'd find a typical pattern. Two of the concepts I talk about are firing order, and that's a concept from Arnold Lazarus. So I would look at how the thoughts, feelings, and actions interacted. Do the thoughts come first, the feelings come first, or the actions? So for example, in the patient that you were portraying, it may have been the actions first, that you try to solve a problem. That seems like a habitual pattern. And then that you might have gotten pushback. And so you might have had a thought like, I'm driving my wife nuts. And that might have led to that, the fear of failure and the fear of being alone. So that's firing order. How are these three things related? And then the next one is focal dimension. So where are we going to focus? So and instead of saying I'm a cognitive therapist, we're going to start with your thoughts. I would ask you. So tell me, Michael, if being the client that you were portraying, if you wanted to start on one of those, do you think the client you're portraying would want to start with focusing on feelings, actions, or thoughts?
I don't know what to do, is what he would say. It's an action thing. He wants to be told what to do, or how to do it, or how to fix things.
Okay.
Fits in with my telephone things.
I would do the Bob Newhart stop video with him. I just say, stop it. But what about?
So what if we started with actions? I would be looking at whether that was effective or ineffective, whether it was a adaptive action or not. And so one of the and the pattern we're getting here is that the trying to solve problems is having an unintended result, and so it's not an effective action. So we might want to look at different actions. So if problem solving is an ineffective action in your family system, what are some other actions you might take? And it might be listening, observing, empathy, and so we would look at different possible actions that might have a different impact on thoughts and feelings, and might have a different impact on your anxiety and depression. So that's how I would do the firing order, focal dimension, and then this idea that there are adaptive and maladaptive thoughts, adaptive and maladaptive feelings, and adaptive and maladaptive actions. So if you, Michael, as that client, wanted to start with the actions, then we would figure out why your attempts at problem solving are having a negative impact on your family. So now we're looking at the interaction between actions and the external factor of this family system. You're driving your kids nuts, you're driving your wife nuts. And then we would begin to experiment with other actions like listening, support, rapport building, that kind of thing, and see if that had a different impact on the social system, and then a different impact on your fear and sadness.
So as part of your approach, when you're doing your working in this framework, do you think it's useful to try to articulate or crystallize like the core issue that drives the like his clingy, passive aggressive, irritating behavior, or is that just not part of what you're interested in your formulation and you're working through?
Well, it's interesting that so the clingy, passive aggressive stuff isn't something that he's aware of yet. Right.
But would you ignore that, or would you make the ego syntonic ego dystonic by saying, by making that, like it seems to me, just from this brief vignette, Michael, I don't know the patient at all, but just from the brief vignette, I would say the guy has personality disorder. Like it's a kind of person, it's a chronic characterological way of relating and operating that he's developed as a strategy over years to protect himself from abandonment or whatever it is that he's protecting himself from. But do you ever get into those domains?
I mean, eventually, but I mean, I think that my foothold into that would be, I'm a problem solver. However, that's not what my family wants.
Right, but it reminds me
hammer.
Right, it reminds me of when I'm working sometimes with couples and someone's what I call hammering for love. They're saying, "Why don't you love me?" Bang, 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 bang. I'm saying, you're not going to get love with a hammer, man or woman. Yeah. Like he's not going to get what he wants by projecting his anxiety and his neediness in what he calls trying to fix things, because that's not what he's trying to do, really.
Yeah. So I'm more interested, if he wants to start with actions, then I'm going to say problem, and
so you'll go with that behavioral level.
Yeah, I'll start where he wants to start.
Uh-huh.
And I think the important thing is for him to realize it's not having the intended result, and that it's and it's making him more afraid and more sad.
So how do you untangle the repetitive maladaptive patterns that patient was exhibiting?
So I mean, some of it's awareness, and building so if he wants to start with behavior, we're going to try and help him become aware of why problem solving is an ineffective action. And then we want him to have a different choices of behaviors that he can try that might have a different impact on his thoughts and feelings and a different impact on his anxiety and his depression. But
So
sure, if he has a personality disorder, I'm going to keep that in the mind. But he's deeply aware of his anxiety and depression, and so we're going to start there. But yeah, I'm aware.
No,
of that.
I agree. Yeah, yeah.
So you'd call this Jeff, the anxious personality disorder?
I would say, I think more passive aggressive is what I would say. I feel like he's when people, usually when I work with people other people, they're doing things that they think are helpful and other people are finding irritating. It's usually a bit of something I wonder about. Is this a passive aggressive? Like they're out of touch with their anger. They can't express their anger directly and use it constructively to guide their relationships. So it reverts to this kind of dripping behavior, this dripping stuff that just irritates everybody around them. But I'm just trying to help.
So
I'm trying to smooth things over.
That's it. So let's say that he was able to make use of this thing where he was, and he realized that over and over that this fear of being abandoned was what was really setting him off. What would how would you clarify that for him and help him work with that?
So in the same way, let's go back to the, effective, ineffective actions. So are these feelings helpful or not? So, so there's a fear of failure. There's a fear of abandonment or isolation, being alone. There's sadness, regret. I've ruined everything. In some ways, I want to know which of those are more helpful than not. And so I'm curious, but the fear seems to generate more action, and so I might want to focus a little bit more on that sadness of, and not that I've ruined everything. I think that I ruined everything again as a exaggeration, but I think it's sad that my attempts to demonstrate love are hurting the people I care about.
Mm-hmm.
And if we can just slow him down and just say, oh man, my wife, I'm trying to help my wife and it's not helping. So let's slow that down and feel that disappointment, but then use that disappointment as a way to think, to see if there are other ways of thinking and acting that might generate different feelings.
And would you eventually think that's going to link to some early relational trauma or context where he felt like he disappointed his father or his mother, could never please them?
Oh, absolutely. And so, so it's having an impact on his current social system in terms of he's irritating his wife and his kids, but it comes from somewhere. So I'm thinking about Karen Horney's things that you turn away, turn against, or turn toward. I mean, I see the client that Michael's portraying as trying too hard, so he learned that somewhere, so yeah, I want to know where he learned this pattern of trying too hard or continuing to try to win approval. And so, yeah, I would want to know where he learned that.
Okay.
And then help him differentiate between this worked with your dad or this worked with your mom, but it's not working with your wife.
Okay.
It's not working with your kids. So
you would say that at one point that was an adaptive strategy that tried to maximize his attachment to whomever he had to try to maintain it by being clingy. Because
yeah, he learned it somewhere.
Yeah.
And he learned it, and it may have worked in this environment, but it's not working in this environment.
So how does the attachment configuration, does that have a home in your model?
Sure. So that attachment is a part of an interpersonal pattern.
Okay.
So attachment styles are one example of an interpersonal pattern. And so, yeah, I think that so one of the models that I use to conceptualize interpersonal patterns is the Laborsky's core conflictual relationship theme method. But that has a lot of overlap with attachment styles, and and what are you doing to try and, absolutely. A pattern of behavior that the client that Michael is portraying, was learned in an earlier relationship, and he's repeating it, but in a way that's not effective with his wife and kids.
So what would you say, Jeff, if you were to try to boil it down, is the curative factor in psychotherapy and healing?
I mean, I think it's pattern recognition and desire for change, but that has to be supported by the therapeutic relationship. So, one of the things that, like even with Michael taking the phone call, probably during the first session, I wouldn't make a process comment about that. But at the second or third, I might about, do you want to know how that impacted me? And so we would want to learn, and
In the therapeutic relation, in the transference, countertransference, you use that as a good way to demonstrate. So this is what you do with your family. Now you're doing it with me.
Yeah, absolutely.
You want to smooth things over, but you don't realize that you're irritating people.
Yeah, I would say, would it be helpful to talk about something you've done that may have had an unintended consequence for me?
So it sounds like you do kind of get into all the domains of the biopsychosocial relational matrix.
Right, but not all at once. And
No, you can't do it at once.
But I want to privilege the ones that are most meaningful to the client. So, so far he's talking, he's very oriented toward his actions because he thinks that problem solving is good. So I'm going to keep doing that, but it's not working within the social system. So that's where I would start. But over time, I would want to talk about where he learned that and how it's impacting us.
So you're expanding the focus of treatment as you start the patient with where the patient is, and then you begin to expand or like you expand the focus, or maybe even narrow the focus at times as the process goes. Expand,
right?
Maybe narrow, dig into like how you're feeling right now.
Yeah, right. And so we talked about firing order being a concept that Arnold Lazarus identified. The other one was bridging, which is you start where the client wants to focus, and then you gradually move over to the one. Years and years ago, I had a client who came in and said, I want to be perfectly clear, this problem has nothing to do with my family. I don't want to talk about my family. They are not at all relevant. And it made me think that her problem might be related to her family. But I can't go there, but I can say, where do you think you learned this pattern? and so that's that idea of bridging, that I'll start where the client wants to start, but I'm going to be looking for other connections, particularly these external influences like the social system or the interpersonal patterns, or some of the internal influences.
When you have assigned kind of homework to somebody, like these 3 steps that you asked, how do you harvest that? How do you work with that homework? What do you do when a person has not done it, which happens?
Yeah, and again, that's a sample of behavior, that when I've had, let's write these down, about 6 months ago, I had someone who's an engineer, a grad student in engineering, who had, it was when we were coming out of COVID, but it was better to meet on Zoom so he could pull up a spreadsheet of his thoughts, actions, and feelings on Zoom. And then, when we started talking more about this is an interpersonal pattern you learn, maybe we should meet in person so our attachment styles can
Commingle.
So that our attachment style can work like they our human attachment styles have worked for millions of years and not, relating to people as flat rectangles like we did for a couple of years. So.
Barb, do you have any, you look like you've got a question on your mind or a comment or a reaction.
No, actually, I'm really fascinated by the way this hour has turned out. So I appreciate what's happening, and I don't have anything to add right now. I think Michael has been persistent in keeping the focus on this client. And, every question you ask Michael, just revealed another aspect of Jeff's approach.
Yes, yes. I think that, I learn best by examples, and you did a great job of explaining
Well, I
what you
appreciate you
do.
bringing in a case so that we had something.
Well, it's always interesting to me to look at the difference between how I describe what I do and how I actually do what I do, because sometimes it's not very consistent.
No,
Like,
Yeah.
I talk about doing it one way, and then when I'm doing it, it's like, oh, what's that? So that's good. I think the clinical examples do get you right into the theory and the technique and the sloppiness of what we do, the messiness of what we do.
Yeah.
It's
Well,
I was going to add, I just want to say, because of the question, like, what if the client doesn't do the homework? And Michael, you just made this character so real to me, but I could just see him coming in and saying, see, I can't do anything right. I can't do this. I can't do that. And or like if what you said, Jeff, about would you be curious about the impact of what you did? And then you'll say, I felt this, and you'll say, see, I always drive people away, and I do this and I do that. So
yeah, I would have said, like, you're a bad boy, and go sit in the corner while I do a little work here. And I do a little work and let him sit in the corner, let him be his little bad boy, because it feels like he's a little bad boy, and that's how he's got that little bad boy.
But I see him as
he will come back and sit on your lap.
I see
Yeah,
him
no,
as
he will. But I think that's so telling,
I
right?
see him as a kid, this building metaphor, he's a problem solver. So I see him as a little kid with the Bob the Builder tools, and he has a hammer, and he wants to fix things. I'm gonna fix this.
Yeah,
So.
I think that's a good. Now that's what you're doing. What we're doing now is fascinating to me. And I sometimes, when I'm with patients, I say, this may sound very weird, but sometimes when I sit with people, I have my own process going on. And I don't know if you want me to share it with you, but I might share something like that, because I think when we do this long enough, we get, at least I do, maybe it's psychotic, but I get these sometimes holographic pictures like that. Like that would be like, yeah, Bob, this little 6-year-old with his tool belt on. Mom and dad are screaming at one another, and he's like, we'll fix this, we'll fix this.
Yeah, I want to fix it. I want to, and I think it's important to realize that his motivation for fixing things is love.
Yeah, he's going to hammer his parents for love. Stop screaming at one another.
But he needs to be aware of the impact.
So do you, Michael and Barbara, have these sort of, when you're working with people, have these these internal? One of my patients once said, sometimes it's like you seem like there are all these tracks that we're following, and then you see the people coming up in the tracks. Do you guys ever feel like that you experience the people, or you can actually talk about?
I just want to say I'm playing timekeeper right now.
Oh, yes.
So I don't know if Michael and I could both answer that question in 30 seconds.
How about if we probably need to sign off
You
now.
can answer now, and then we can do the other one.
Yeah, people hang around. We're going to sign off now. Thank you all for attending tonight. Thank you, Jeff. This was fascinating, interesting, and we'll be around for people who
Lots
want
of
to
fun.
watch us debrief. So we're going to stop recording, and feel free to stay with us and ask questions, and I'll unmute you and you can interact. Thank you all, and good night.